Hello AJR readers, my name is Joon Seok Kim from South Korea. It is a great pleasure to introduce our research findings to you. The title of our study is Artificial Intelligence Model for Detection of Colorectal Cancer on Routine Abdominopelvic CT Examinations, a Training and External Testing Study. This research was supported by these funding sources. The primary difference between CT colonography and routine abdominopelvic CT is that the former requires bowel preparation. Such special protocols are necessary because CT colonography is specifically designed for detecting colorectal polyp or cancer. On the contrary, routine abdominopelvic CT is performed in a wider range of clinical scenarios. As a result, the detection rate of the colorectal cancer in routine CT is inevitably lower than that of CT colonography. According to one study, the sensitivity was reported to be about 72%. Another study found that as tumor size decreases, the sensitivity further declines. However, the problem is that radiologists sometimes fail to detect tumors even when they are not small. One study evaluated the colorectal cancer detection rate among general radiologists using routine CT and found that the sensitivity was only 66%. Interestingly, when these initially missed cases were retrospectively reviewed, 59% of the lesions were successfully identified, improving the sensitivity to 86%. This suggests that even colorectal cancers large enough to be detected on routine CT are sometimes just overlooked. Multiple factors may contribute to this phenomenon. Of course, this may be because the radiologists in this study were not gastrointestinal experts. However, even expert radiologists can also be affected by excessive workloads and eventual burnout. In this context, leveraging artificial intelligence to automatically detect colorectal cancer could help reduce errors made by human radiologists. Routine abdominopelvic CT has become one of the most widely used imaging tests across a broad range of clinical settings. Therefore, developing a model that operates on routine CT rather than CT colonography would significantly enhance its practical applicability. The purpose of this study was to develop an AI model capable of detecting colorectal cancer on routine abdominopelvic CT exams performed without bowel preparation. We collected CT images from 2,662 patients with histologically confirmed colorectal cancer at the tertiary hospital in South Korea. From these CT images, we selected approximately 31,000 axial slices containing colorectal cancer, along with about 17,000 randomly chosen slices from the remaining normal images to construct a training set. The trained model was tested on patients from the same institution as well as patients from an external medical center. The both testing data sets included consecutive patients who underwent both CT and colonoscopy within the 2 months interval between January and June 2018. From the internal testing data set, a total of 841 patients were enrolled, of whom 99 had colorectal cancer. For the external testing data set, 442 patients were enrolled with colorectal cancer confirmed in 29 of them. A radiologist specializing in abdominal imaging, myself in fact, established the reference standard. For all colorectal cancer patients in the training set as well as both the internal and external testing set, I carefully reviewed colonoscopy reports and, when available, surgical and pathological reports as well. Based on this information, I labeled bounding boxes to precisely encompass the tumors as accurately as possible. We used DETR, detection with transformer, for the colorectal cancer detection task. The model was first pre-trained on the COCO dataset and then further trained on our training dataset to perform slice-level prediction for the presence of colorectal cancer. At the same time, we utilized open-source model called Total Segmentator to obtain colorectal masks. When the bounding box predicted by DETR overlapped with the colorectal mask, a new larger box was generated encompassing the both boxes. The image within this new box was cropped and then fed back into the DETR model to refine the final bounding box. If the final bounding box overlapped with reference standard box, it was considered a correct prediction. This model architecture was designed in an end-to-end fashion. When the AI predicted bounding boxes were present on contiguous slices, like this, those boxes were considered to belong to the same lesion. In this scenario, the lesion's overall prediction score was defined as the arithmetic sum of the prediction scores of the bounding boxes for the individual slices. Both lesions shown in this example overlap with the red reference standard boxes and were therefore classified as true positives. Now, let me show you the results of our study. In the internal test set, colorectal cancer was detectable in 92 out of 99 colorectal cancer patients. In the external test set, 26 out of 29 colorectal cancer patients were determined to have CT detectable cancer. Approximately 10% of the patients had tumors smaller than 2 cm. The black graph here represents the AFROC curve for the internal testing set. The Uden index reached its maximum when the threshold for AI predicted lesion scores was set at 3.9996. At this threshold, the sensitivity and specificity were 79.6% and 91.2% respectively. We applied the same threshold value to the green curve, which represents the external test set. For the external test set, the sensitivity and specificity were measured at 80.8% and 90.9% respectively. The AUC values were 0.867 and 0.808 for the internal and external testing sets respectively. For the external test set, we also conducted a human reader study. 2 gastrointestinal readers were asked to identify colorectal cancer, and their performance was compared with that of our AI model. While their sensitivity was similar to that of AI model, their specificity was significantly higher. This table presents the 9 cases in which at least one of the 2 readers failed to detect the cancer. Among them, the AI model successfully identified the cancer in 5 cases. This table shows the results of a subgroup analysis based on the size and morphology of colorectal cancer. When the tumor size was smaller than 2 cm, or it involved less than 50% of the bowel wall, the AI model and human readers all exhibited lower sensitivity. Now, let me show you some example images. Red boxes represent the reference standard, while yellow boxes indicate AI predicted boxes. This case from the internal testing set demonstrates a successful cancer detection by the AI model. This case is also from the internal testing set. The AI model placed the bounding boxes on the descendo-sigmoid junction colon, where colonoscopy revealed no evidence of cancer. Here is an example from the external testing set. The AI model successfully detected sigmoid colon cancer. This lesion was missed by both human readers. Here is an example of a false negative case from the external testing set. The AI model failed to detect a polypoid cancer in the sigmoid colon. However, both human readers correctly detected this lesion. In conclusion, our study demonstrated the potential utility of an AI model for detecting colorectal cancer on routine abdominopelvic CT examinations performed without bowel preparation. The AI model may help reduce the frequency of missed colorectal cancers on routine CT scans, regardless of the original indication for the scan. Okay, that concludes my talk. Thank you for listening.